Good morning to all of you. Good afternoon, good evening, wherever you are. My name is Vikram Patel. I'm the Paul Farmer Chair and Professor at Harvard Medical School. I chair the Department of Global Health and Social Medicine. Thank you for all of you who've signed in at time. Let's give a couple of minutes before we start this webinar. I'll just pause for a minute or two to let people sign in. There's quite a few who are signing in right now. All right. Well, once again, good morning to all of you. This is Vikram Patel. I am the chair of the Global Mental Health at Harvard Initiative at Harvard, which is at Harvard University. I also chair the Department of Global Health and Social Medicine at Harvard Medical School. I want to welcome you all to the first of a new series of special lectures that the Global Mental Health at Harvard Initiative is organizing. This is a series that is intended to celebrate the work of champions, of ambassadors, of leaders of the field of global mental health. And our plan is to have 4 lectures each year. The lectures for this year have already been announced in our newsletter, and I'm absolutely delighted and honored to introduce the first of our lecturers of the series for 2026, Professor Sir Graham Thornicroft. But before I introduce him, I wanted to just say a few words about the initiative at Harvard and how you can continue to stay in touch and share information about what we're doing with your networks. Global Mental Health at Harvard was launched in 2018 as a cross-university initiative to bring together scholars from diverse disciplines in Harvard who are interested in working on issues related to mental health, every aspect of mental health, from understanding what shapes our mental health, what leads to mental health problems, and how we can prevent and address mental health problems at a population level and in individuals who are struggling. The Global Mental Health at Harvard Initiative has a number of different activities. A key one is a weekly newsletter, which anyone can sign on to, but importantly, anyone can also contribute to. The newsletter is intended to be a sort of a clearinghouse about resources, events, publications, and activities and vacancies in the area of global mental health. If you're not already receiving the newsletter, please do sign on. My colleague Katie, who coordinates the initiative, will put the link to sign on to the newsletter in the chat of the Zoom window that you have signed into. Today, we're going to hear from Professor Sir Graham Thornicroft. He will be speaking for about 40 to 45 minutes, and then we will have a brief fireside chat with myself, and then we will bring in audience questions. Please use the Q&A section of the Zoom window to put your questions in, to insert your questions. We will then curate those questions, especially those questions which seem to be appealing to many of the audience. So now it gives me great pleasure to introduce our first Frontiers in Global Mental Health series lecturer. Graham Thornicroft is a Professor Emeritus of Community Mental Health at King's College London. He's a consultant psychiatrist at the South London and Maudsley NHS Foundation Trust, working in a local community mental health team in London. He's a National Institute of Health Research Senior Investigator Emeritus, a Fellow of King's College London, and an Honorary Fellow of the Royal College of Psychiatrists. Graham has made tremendous contributions both in his own country, Britain, as well as in global mental health. In the UK, he has been a singular leader in the development of mental health policy in England, including chairing the External Reference Group for the National Service Framework for Mental Health, the National Mental Health Plan for England for 1999 to 2009. He's also been a champion of global mental health and chaired the World Health Organization's Guideline Development Group for the MHGAP, the Mental Health Gap Action Program Intervention Guide, across all 3 of its editions. This is, of course, a very well-known guide, one that is intended to be a practical support for primary care staff to treat people living with mental, neurological, and substance use conditions, particularly in low-resource settings. The guide has transformed mental health care across the world and is being used in more than 100 countries. He's also played a number of other roles in the WHO and significantly in all of his great academic contributions, particularly in the area of serious mental illness and on stigma and discrimination. Most recently, he co-chaired the 2022 Lancet Commission on Ending Stigma and Discrimination in Mental Health. And in 2024, he co-led the writing of the World Health Organization Mosaic Toolkit to End Stigma and Discrimination in Mental Health. Graham has written over 730 peer-reviewed papers in PubMed, more than 34 books, 7 of which have won awards, and he's one of the most highly cited researchers in the world. But I want to add a few words, personal words of my own experience of Graham. Graham has been a sort of mentor, apart from being a collaborator for me personally. He and I worked very closely together on a large program which intended to provide community-based support for people living with chronic schizophrenia in India, which culminated in a randomized controlled trial that was ultimately published in the Lancet. And I can vouch for the fact that Graham is not only a tremendous intellectual, but has deep compassion for working with and supporting people living with serious mental illness. So I can't think of a better person to kickstart this series on the frontiers in global in mental health. And I invite Graham now to give us his remarks. As I said, after his remarks, we will then have a Q&A session inviting all of you to please include your questions in the Q&A box. Graham, what an honor, what a privilege. Thank you for joining us today.
Vikram, thank you so much for that very, very kind introduction. And thanks to you and to Katie for organizing this meeting. And greetings to everyone, wherever you are at the moment. And I greet you on a cool but rather sunny spring day from London after a cloudy and a rather dull winter that went on far too long. So the blossom is on the trees and things are looking good. Now let me share my slides first of all. And perhaps, Katie, can you confirm that you can see slide 1 full screen mode, please?
Yep, slide 1 is up.
Very good. So my title today is How to Reduce Stigma and Discrimination in Mental Health. And as Vikram mentioned, I have 2 particular perspectives upon this and many other issues. One is I'm a practitioner. I work as a psychiatrist. I've worked in community mental health teams in South London for about 30 years. And the last year or 2, I've been working in a team for people who have severe mental illness and who are homeless in South London. On the other hand, I'm an academic and a researcher. And you can see here our base, health service and population research. And so I'll be bringing these 2 particular perspectives, some of which sometimes focus, but not always, to this talk today. So rather than finishing with my main message, I'm going to start with my main message to you. My request is this: please remember from this talk today only 2 words. And the words are social contact. And to emphasize that, I should offer them to you in red. So the words are social contact, and I will tell you more a little bit later about what I mean. So this story starts about 20 years ago. By then, I've been working already in mental health about 20 years, and I developed a type of uneasy feeling. I just felt ill at ease, which was something to do with feeling that working in mental health is somehow qualitatively different from working in other aspects of healthcare. I thought I'd put my finger on it by identifying stigma as a critical issue, and I made a ridiculous proposition. I said to my boss, I'd like you to give me a year to stop everything I do and to write a book. And to my amazement said yes. And this was the sort of incident that triggered my passion. This is, or was, a home for older people in the north of England. And there was a proposal to turn it into a home for people with mental health conditions. And out came neighbours with petitions, marches, placards marching on the town hall and so forth. And this is stigma from the point of view of a person with bipolar disorder. And Bill McKnight wrote an amazing book with his very short, sharp poems, is now, I think, on his fifth book of poetry. So the book that I did write then wasn't so much about stigma, but more about discrimination. And I'll tell you why. Reading everything I could about every aspect of stigmatization, mental health, and otherwise, I wanted to come to a simple and clear approach that at least I could understand. And it seemed to me that there are aspects of knowledge and attitudes and behavior within the overarching, the umbrella concept of stigma. Knowledge is the fact that in many places, most people know relatively little about mental health questions, and much of the information they have is actually wrong. Attitudes refers to the emotional, the affective reaction of people with mental health conditions, very largely negative, not altogether, but very largely. And behavior, I came to the view that this is the most important domain, actual behavior towards people. If you develop a mental health problem while you're working, will you keep your job? If you go back to your job, will you be promoted? Will you get the same pay prospects? Are your marital prospects damaged if you're known to have a mental health condition or a mental health diagnosis? So I came to this at an early stage about how to understand what stigma consists of. I then teamed up with colleagues, particularly Professor Norman Sartorius, to try and understand the nature of stigmatization in more detail. We made perhaps a ludicrous suggestion. We wrote to about 25 colleagues around the world and said, we want to do a global project about stigma, but we have no money. And would you like to join in? In fact, everybody said yes. And in fact, it took me over 20 years to get any grant income for stigma research because funding bodies were so aversive to the whole idea. In this first study, we interviewed about 700 people to understand the direct reports of experience of discrimination from the point of view of people with schizophrenia. And they gave us a pretty poor picture. About 90% says, yes, we have been discriminated against because of the condition. The nature of peer review in science is that people challenge you, which is good, of course, but sometimes doesn't feel good. And people said, well, this is ridiculous. Schizophrenia is the most stigmatized condition. So we took that as an invitation to test it empirically. And in the next study, now the network had grown, we interviewed over 1,000 people with major depressive disorder, severe depression, across 35 different countries. And in fact, almost as many reported experiences of discrimination, about 80%. And then a couple of other things surprised us. About a third of these people in many countries around the world said that after developing the condition, family members or close friends had completely abandoned them. They also said something quite interesting, which is they could not have predicted in advance which people would stick by them and which people would walk away. And they learnt who really counted in their lives by that distinction. Another thing that we discovered is that a third of people said that they had stopped trying to do things that were important because they expected to fail. For example, applying for a job, for example, wanting to join a local sports team or a choir, whatever people like to do. So we called that anticipated discrimination because people said, why try? Why even bother to apply for a job? Because I'm really not going to get it, am I? We wanted then to understand the whole nature of how this set of concepts of stigma works in more detail. So under the three headings of knowledge, attitudes, and behavior, we developed a series of measures to understand each in more detail and about how they vary and how they co-vary. You can see here the scales. We still make these scales available to everybody who'd like to use it, but with a few conditions. You can use them if you don't change the scales, and you can translate the scales if you then put those translated versions back into our central repository for other people to use freely in future. And on that basis, we now have many, this is not quite up to date, many different language versions which are being used for international and cross-cultural, cross-country comparative stigma research. But there was a limit to how much I wanted to keep describing this reality of stigma. And I became more interested in the question, what can we do to reduce stigma and discrimination? So we then did a systematic review for the Lancet about this, and these were the main findings. Social contact seemed to be emerging as the most active ingredient. And what does this mean? It means occasions where people who do have a mental health condition or who have contact with people who do not have such experiences. This is now about 10 years ago, and most of the evidence then was of so-called in-person or direct face-to-face contact, and so the evidence supported that as the mode of delivery. There was some early evidence for video or streamed online, but not very much. Nearly all the intervention studies for young people took place in school or in college, and the evidence also suggested that the social contact principle held, but we found that only 10% of all the studies we could identify came from low and middle income countries, even though, as we know, 85% approximately of the world's population live in these countries. So we identified this possible active ingredient of social contact. From that stage, there developed a series of large-scale, indeed national-level, intervention programs to reduce stigmatization, and also a progressive increase in research interest among both academics, but also to some extent funders in these questions. You can see here in the upper line in the orange, the number of papers published per year on mental health and stigma. And on the lower line in blue, numbers of papers on mental health and discrimination over about the last 10 to 15 years. And a real increase in interest in the evidence base of these issues. So the large-scale programs here, and you can see immediately that they're all high-income countries. And indeed, we developed, this is going back now about 15 years, a large program in my own country called Time to Change, my own country being England in this case. And you can see at the bottom, you can see a little sign saying King's College London, and our team were identified as the so-called evaluation partner. And so our job is to say, is this working or not? Are we actually gaining any traction for stigma reduction? So all I can do is give you a few headlines because there are many papers on this. We did a stock take after 5 years and found evidence in many areas of stigma reduction, and also a cross-section after 10 years when we compared the results with similar programs in Canada and in Sweden. And to give you a couple of examples about the nature and the scale of the advantage. This was public attitudes. So we employed an opinion polling company, and every year they did a representative sample of national people across the population in England. And we found, approximately speaking, about a 10% improvement over these years of people changing their views about mental health. Now, on one hand, this wasn't, it wasn't ending stigma. On the other hand, there had been, until about 10, 15 years ago, a view that people took, either that stigma is too complicated, it's just too difficult, don't bother, or that stigma is somehow intrinsic to the human condition, that we necessarily have tribes, we have our in-group, we have us, we have the other, and this othering is a vital part of human connectedness. And a consequence of that is you can't actually change having negative views against outsiders and outsider groups. Well, we've shown that's wrong. It's also been shown to be wrong, for example, with respect to stigma and discrimination in the fields of HIV and AIDS and in tuberculosis and in epilepsy as well. I mentioned earlier that I think of the 3 elements of knowledge, attitudes, and behavior, that behavior is most important, but it's also the most difficult to measure. We did develop a short scale led by my colleague, Sarah Evans, called an intended behavior scale. It's RIBS. And here we found again several distinct improvements. A greater willingness to live with a person with a mental health problem, or to work with, or to live near, or to continue a relationship. You can see again the scale of the stigma reduction, 5, 10, 15%. So this hasn't been transformative over a decade or so, but it has been inching forward with the retreat of stigma across a whole country. We decided that the touchstone of behavior change were reports of actual discrimination by people with mental health conditions. And so each year we phoned up 1,000 people across England who were being treated by mental health services for severe mental illness. And we used a scale called DISC, Discrimination and Stigma Scale. And again, we found very similar results, reductions of 5, of 10, of 15%. For example, of discrimination experienced from family members, discrimination experienced by friends, or in dating or trying to develop intimate relationships. It's really over the last decade that we've seen more evidence developing from, if you like, the majority world of low and middle income countries. I'll give you a couple of examples. Here are some projects from India. These are led by my colleague, Professor Pallab Maulik at the George Institute. And then in this early study, they developed an intervention based again upon the principle of social contact, which is a small play put on under, it's like a tent with a stage in a village. There'd be a short presentation, typically middle-aged parents with a young adult child developing a mental health condition, and then showing the challenges and early stages of recovery. And then an open discussion mediated by the elders or significant figures within the local community. More recent projects, and the results of this show that 1 year after these interventions, and a pretty large-scale project carried out in 42 villages across Andhra Pradesh, we showed improvements in attitudes and behavior and help seeking. Now, for those who say that stigma is a rather vague and useless context, I challenge that, because one of the most important consequences of stigma is people who delay or choose not to seek help for their mental health problem. And so improved help seeking is a major asset which can flow from stigma reduction. Now, interesting as well, a lot of stigma intervention projects do 3-month, perhaps 6-month follow-ups, occasionally 1 year. But this project went one step further and carried out a follow-up 2 years after the intervention, and quite strikingly found that stigma reduced further during that 2nd year. And they also looked into some of the more practical, pragmatic issues about the operational challenges. For example, that it's useless putting on these village shows on the topic if it's not at a time that the villagers can actually attend because of any conflict with their other duties. More recent work has been focusing upon mental health in young people. For example, in this Artemis project in sorry, my pronunciation may slip here, Vijayawada and in Delhi. And this is for teenagers, for young people who have a mental health problem or are at high risk. And in the spirit of co-production, co-development, the idea for the intervention was led, in this case, by young people. Now, I don't know if you know this game in your country. In my country, it's called Snakes and Ladders. You take a dice, you throw it, and then you go move around a board. And the aim is to get to the end, which is square number 100. Interestingly, I played this recently with my young granddaughter, and she won 5 games running. And so here, the messaging, the text on the board is about mental health issues. This is another example, again, a game you might know. On here on the pavement, you might be able to see chalk markings. And this is a game called hopscotch. Children stand on 1 leg and then 2 legs and 1 leg and then 2 legs. And all of the text, all the messaging, the narrative element is on mental health. The third example, again, suggested by the young people, is a magic show. People love magic. So in the hat can come out a bird, perhaps, or a rabbit, or a ribbon, or something. But on the back, you can see that the text within which the entertainment takes place is about mental health. So the principle here is that the form of social contact being used doesn't have to be serious or earnest or boring. And in fact, perhaps it could and should be fun as well. And in India as well, there have been a number of celebrities. This is, you may have come across Deepika Padukone, who's not only endorsed, but has also spoken about her own difficulties of mental health problems. And indeed, there's a question about whether celebrities actually add anything to an anti-stigma program. So recently, my colleague Petra Gronholm and I looked into this. And to be honest, there's not a lot of good evidence either way. It looked like celebrities can, if you like, open the door to the topic of mental health, and they can make discussing mental health sort of possible or talkable. On the other hand, people often say, well, it's all very well, but these people are rich, they're famous, they're insulated, they can take a risk, but ordinary people can't, for example, in disclosing about having a mental health condition. So I think that the provisional answer at the moment is celebrities can assist as part of a mental health program, but only as an element, not as the whole program itself. I want to give you a few details about work happening in Nepal, this being led by my colleagues Brandon Court and Drishti Gurung. And the key point here is this interesting intervention called photo voice. The question for this project is, can stories developed by people with mental health conditions reduce stigma among primary healthcare practitioners in Nepal? So the stories are illustrated because the people with conditions are given cameras, they take lots of pictures, and they're assisted to produce something like a 10-minute presentation with PowerPoint slides. Typically, the intervention has three parts. There's the so-called status quo ante, which means my life before the start of the mental health difficulty. What happened when I had the mental health crisis and I was actually worst affected by the condition. And then the period of recovery, or sometimes complex period of recovery, or what happened after the initial crisis. And many of these are very moving accounts, and the provisional evidence accumulating among these primary healthcare staff in Nepal is this can play a part to reduce stigma among healthcare staff, of course, of whom are very important gatekeepers, both to physical and to mental health care. In many other countries now, including my own, but around the world, there are more and more people who are known in the public eye and who've also chosen to speak about their own experience of having mental health difficulties, a whole range of difficult problems. You can see here some examples of people who are well known in South Africa. I mentioned the Time to Change program in my country, and this was then extended to several countries in sub-Saharan Africa. And the central question was, does the concept of social contact still have any efficacy, any salience in other countries in many ways different from, for example, in the UK? So there's some of the materials here you can see to depict mental health issues. It's actually difficult, I think, to find images which are both accurate and sensitive at the same time. We had in my country many images used. We called it head clutchers. So typically a mental health story in newspaper had a silhouette, had a young woman, usually in profile, clutching their head, looking like persons in anguish or despair. And indeed, we had an anti-head clutcher campaign for a period because that was actually not a positive image to portray about mental health conditions. You can see here some of the material used in Uganda demonstrating the importance of talking. And indeed, it's the sort of this myth busting is one component part of anti-stigma work. For example, in my country at least, it's commonly thought that if you think a person you know is depressed, then you don't talk to them about it because it can transmit. You can be contaminated. They may maybe make you depressed, so you don't talk. Or let's say you know somebody who you think might be thinking of suicide. And the myth is you don't talk about it because talking about it could trigger them into doing something. Again, no evidence for this. But there are a number of myths which can actually stop people offering help and support, which can make a difference. In the campaigns which were delivered by non-governmental organizations, they deliberately use social marketing techniques. Social marketing are advertising techniques used not for profit, but for a social good. And here you can see that the images, we're looking at the 1 in 4, 1 in 5, the prevalence data we often hear. And the title was deliberately developed to so-called cut through. That means to reach important constituencies targeted by the campaign. A similar program, however, in Kenya came up with a different title because the meaning of that title spoke with more resonance in that setting. And you can see here some of the key messages put across literally, on the T-shirt. You have the T-shirt as ways of portraying the central messages of the campaign. So here is Edwin, one of the leaders in the campaign in Kenya. And he says, "When I keep quiet, stigma wins. And I can't let that happen." So we've been able to deliver this program. Did it make any difference? And my colleagues Laura Potts and Claire Henderson looked into this and used the same scales and the same evaluation as we did for the similar campaign in England. TTC here stands for time to change. And I was interested to learn that the effect of the social contact interventions in these countries was essentially very similar to that in my own country as well. So what does this mean? It means that if you take social contact and you carefully adapt it for culture and context, then it can be effective in different places and in different times. So it seems so far from the more recent evidence that social contact can be as effective in low and middle as in high-income countries if it is adapted appropriately. Clearly, there are vast resource differences, and we can only do what is possible in any particular site. And it's important to know, even if you get short-term gains, are they maintained over time, with or without boosters? And also, I think one of the lessons from the Indian work is that the interventions could be actually entertaining as well as informative, as well as effective. As Vikram mentioned, it was my honor actually recently to be invited to lead a Lancet Commission. As you may know, these are sort of long form documents, often with a half-life intended to be 5 years or more, on an important aspect of public health to bring together all of the information and to make, preferably, a small number of clear recommendations for action. And I co-led this with Charlene Zunkel, who set up the Global Mental Health Peer Network, and that's been renamed recently as AVE's Mental Health. And here's Charlene, who is a person who hears voices, a remarkable polymath who lives in South Africa. So you can see at a glance that we had many people from around the world contributing from many different backgrounds towards this Lancet Commission. And it was published in all 6 of the World Health Organization main languages, in Arabic, in Chinese, in French, in Russian, and in Spanish. So what was this commission for? First, to offer a definition of the field, to say something, although not very much, about the impacts, because there's so much already published here. To look at the evidence of effectiveness of interventions, to see whether scaling up to a large scale is possible and reproducible, to look at the roles of the media, and to make a few recommendations. So without going into too much detail, we had many people from different countries, different continents, And we especially wanted a very strong representation with people with experience of mental health conditions. For that reason, we had the agreement from the Lancet to include poems and quotations of people with lived experience. We were surprised just towards the end of the process that the Lancet said, I think you can only have 8 poems, but we'd had over 100 submitted. So we had to choose just a few poems. But we wanted to bring the voice of people who experience the conditions right to the fore. We decided to suggest that there are 4 main types of stigma. The first is sometimes called internalized stigma. I think probably self-stigma is a more accurate proposal, which means the stigma that is learnt by a person with a condition from incoming stigma from other people, which they then apply to themselves. For example, the anticipated discrimination I mentioned earlier. The next category has, strangely enough, several different titles, sometimes called family stigma, courtesy stigma, affiliate stigma, stigma by association. Effectively, this is the stigma experienced by people in the family of the person with the condition, and also people associated, such as mental health professionals, maybe to do with the feeling that I had before I wrote that book. The third domain is public stigma that I mentioned earlier. And the fourth, which so far I think is the least well understood and also the least researched, is called structural stigma or systemic stigma. So let's look at a bit more detail about this structural question. And I'll start with the question about how often, or in fact, more precisely, how rarely people with mental health conditions receive any treatment, let alone effective treatment. This is work done by the World Mental Health Surveys, as you can see, led by Ron Kessler. And the starting point was to take the question of major depressive disorder. So if we think, for example, across the whole world of all people with major depression in a year, and we know it's about 4% in most populations. If we take among people with the condition, this 4% of everyone, the percentage of people who actually receive treatment in high-income countries, then the answer is about a quarter. The next circle looks about the people in the medium-income countries. So of people with major depression, it's about 11%. And next, if we think about people treated in lower middle and low income countries, it's about 4%. Taken as a whole, one could say approximately that about 10% of people with major depression receive any treatment. And this is not mild to moderate. These are people who are often severely impaired in everyday life, may have suicidal ideas, may struggle to participate meaningfully in occupational, in family, in relationships, and so on. So the starting point here is that the treatment gap, even for one particular, often severe condition, is huge. The flipping of this, the inverse, is that if 10% are treated, 90% of people are not. So here we see that from a recent World Health Organization document, it estimates about 10%, 9% of people with depression receive adequate treatment. Now, just pause for a moment. If we were talking here about strokes, heart attacks, cancer, diabetes, and we said only 10% of people receive treatment, this in many countries would be seen as a national scandal. Well, I think these data suggest that we do have an ongoing, quiet national scandal because of these degrees of undertreatment. We know that depending on how you measure it, between about 20 and in fact 30% of disability is attributable to mental health problems. And yet, do governments actually spend 20 or 30% of their health budgets on mental health? Of course not, not at all. On average, across many countries, it's 2%, and in some countries, it's down to about half of 1% or less of the health budget spent on mental health. So when I speak about structural discrimination, one of the best examples is the miserably low levels of investment by most governments in mental health care. You can see here some of the data. I won't dwell on the details too much, but you can see even in high-income countries, 5% of health budgets, far less in other countries. The next issue addressed by this Lancet Commission is some of the impacts of stigma and discrimination, and I can summarize these fairly briskly. In virtually every domain of life, there are adverse effects for marginalization and social exclusion, whether you're thinking about education, in the workplace, marriage, parenthood, human rights. Stigmatization damages and jeopardizes those forms of social participation. Let's take one example here that's perhaps less often discussed, which is the criminalization of suicide. This is work done by United for Global Mental Health. I need to disclose an interest because I chair the board. So the scale of the challenge here, over 700,000 people dying by suicide each year. Indeed, just a few minutes ago, I was speaking to a colleague who has known a young person for 20 years who tragically took their own life just recently near to where I live. And the stark finding that I found impossible to forget is shown here at the bottom, that across the world, every 40 seconds, somewhere in the world, a person takes their own life. Now, it's only fairly recently I've become aware that in over 25 countries around the world, suicidal people can be arrested, prosecuted, fined, or even put in prison if they attempt to take their life but do not succeed. Quite a lot of these countries, in fact, have post-colonial laws that make these provisions, sometimes which are being repealed. And you can see here the scale of the challenge. But there is actually some progress being made. And in recent years, we've seen the decriminalization of suicide in Cyprus, Ghana, Guyana, India, Malaysia, Pakistan, and Singapore. So I suggest that the criminalization of suicide is another example of structural stigma, of structural discrimination. In this Lancet work, we found that derogatory terms were not even common. They were the rule across many countries of the collaborators in this project. You can see here some of the horrible words used in English. And we came to the recommendation to use the so-called person first formula. You may be familiar with this from the phrase, a person with HIV or AIDS. And similarly, you wouldn't say diabetic, but maybe a person with diabetes. And we suggest you don't say, depressive, but a person with perhaps experience of depression and so on. My colleague Charlene Zunkel also commissioned a special survey as a part of this Lancet Commission work, and there are about 400 participants from over 40 countries in the 6 languages I mentioned. Here are the main findings. So people universally tended to agree that stigma is a problem. And again, one finding stood out in my mind, which is this one. So remembering these are people with many different types of mental health condition. Many of these people are people with severe mental health difficulties. And yet, most people said that stigma and discrimination can be worse than the impact of the mental health condition itself. So for those who say, well, stigma is regrettable, but it's not really a big problem, I think this puts that idea aside. But do we know what to do to reduce stigma? As a part of this Lancet Commission work, we looked carefully at the evidence, and we carried out something called an umbrella review of all of the evidence we could find. And we found a huge amount, over 200 systematic reviews about stigma reduction, which we were able to boil down and to synthesize. And again, the idea of social contact came out as primary. Social contact meaning direct, or indirect contact between people who do and who do not have experience of mental health conditions. But the evidence now of the impact of the indirect, of remote, of online, of social media, of digital was stronger. And indeed, the evidence appears to be that properly curated and properly delivered, indirect contact can be as effective as direct in-person social contact for stigma reduction. There isn't time to go into really any detail about the large-scale programs, but we did choose 10. We added to our commission report an appendix of about 100 pages, putting lots and lots of detail about how these programs were developed, how they were funded, how they were delivered, how they were evaluated, and showing that there are many examples about how to carefully adapt the principle of social contact to particular settings. I can summarize the roles of the media simply. It can play a role either for good or for harm. For good, where they might, for example, use reporting guidelines on reporting suicide. For harm, where they simply reinforce negative stereotypes. One example I came across recently is that there was a notable South Korean film called Parasite, which a couple of years ago won an Oscar. And tragically, one of the leading actors took his own life a couple of years ago. Reporting guidelines on suicide reporting were not followed consistently in that country, and the method of death was reported widely. And in the few months after that death, there was a spike among middle-aged men using that particular technique for people who took their own lives. Today's not the time to go into all the recommendations, except for one. The Lancet Commission proposed that the WHO should produce a simple, practical, realistic guide or toolkit about how to reduce stigma. And to give credit to the World Health Organization, they've done actively exactly that. So this is called, as Vikram mentioned, the WHO Mosaic Toolkit to End Stigma and Discrimination in Mental Health. It's a PDF, it's freely available, you can download it, you search Mosaic Stigma Toolkit, and you'll find it. And it consists of a few principles. Because of the importance of social contact, it means that people with experience of mental health conditions are central to everything in stigma reduction. It also talks about the importance of inclusive partnerships. No single organization or agency is likely to be able to get the traction and the push over a period of time to make a program effective. You can see here some of the contents about what to do. Again, lots of case studies of practical programs, both large scale and tiny scale. One of the case studies is a man in my country who wanted to do something. So he took a small table and a chair to the entrance to the train station. He set up what is called a living library, put a notice saying, mental health, come and talk to me for a few minutes. And people sit down. The library meant people didn't borrow books, they borrowed his time, so they'd enter into discussion about mental health issues just before they rushed to get their train. And so whether you have a large consortium, or in fact, even as a single individual, you can still use the principle of social contact to do something effective to reduce stigma. And this particular Mosaic guide is a very practical, step-by-step, almost a cookbook approach. And it takes you through each of these stages, and it has sub-stages saying what do you have to consider, what's been shown to be good practice, effective practice, and also resources towards the end of the guide. So here's the actual source, but you just put in Mosaic Stigma and you will find it. So I began with my central message, and I will, so I'm about to finish with my central message again. So social contact, these are the only two words I'd like you to remember from this talk today. So my main message is this. This is not a question of tokenistically involving a few people with experience. People with lived experience are the central active change agents to reduce mental health stigma using social contact. But it's not any contact, just a word about some of the conditions under which social contact can be more effective. So the first is that the speaker, often speaking about their own personal experience or the narrative, is trained to convey the story very well. But often there'll be different forms, some verbal, perhaps some video, because different people absorb and take messages best in different ways. For practitioners, there needs to be a special focus on what to do, what to say, not making abstract statements, but this is what you can ask, this is how you inquire. Very specific things, specific open or even specific closed questions that can actually help to get into the topic area. I mentioned myth busting earlier. These sessions do best where there's an enthusiastic facilitator focusing upon the stories at hand, and where the stories relentlessly emphasize recovery. Of course, not always step by step. And also, sometimes people may have enduring difficulties or disabilities, but a focus upon the recovery goals of an individual and how friends and perhaps services can help the person towards achieving those personal recovery goals. Every couple of years is a large international meeting on stigma. And a couple of years ago, this was a meeting in Copenhagen. Now, you can't see the scale here, but these are blocks of ice about 1 meter high. And at the bottom, you can just see a few cables which act as a very slow heater. And over the course of the conference, stigma slowly melted away. And this is my vision of what I want to see, I hope, within my lifetime for stigmatization. The next of these large-scale conferences is taking place later this year. You can see the dates in November, organized by AIMS in Delhi and the George Institute. For people who'd like to read a bit more, perhaps about wider issues of community health, here is a community mental health textbook, came out a few months ago, including a large section actually on global mental health. For people interested in the questions about leadership within our area, this is also published just recently about practical and professional leadership skills. And people interested in global mental health, as well as all the wonderful teaching, of course, at Harvard, this is another opportunity to consider, which is a course at my own university, King's College London, delivered jointly with the London School of Hygiene and Tropical Medicine. So far, I've been speaking largely about stigma as if this is a topic of academic interest. But for me, it's more than that. It's also a question of personal experience. When I was very small, my mother, you can see her here, had a period of deep depression. And in fact, she was suicidal herself for quite some time. The medication didn't help her at all, but she did have electroconvulsive treatment, ECT. Interestingly, the doctor treating her said, as she recovered, you will never become depressed again. I find that a remarkable thing because the patients I treat, because I can't predict the future very well, I wouldn't say, I can guarantee you'll never become unwell again. But the doctor did say that. Unfortunately, it was true. Some years later, I interviewed my mother, interesting situation, and she told me, among many other things, these statements. I gradually lost weight and I started thinking I might gas the children in the oven. I desperately needed help. I would never wish depression on my worst enemy. I hope that people are more understanding these days. So I hope that during this talk, you'll have the impression that in many cases, especially where there are organized anti-stigma campaigns, we are seeing movement towards people being more understanding these days. And especially among young people, there's a greater readiness in many countries to speak about mental health, to explore mental health issues on the social media and artificial intelligence, whatever the provenance of that information might be. So once again, let me thank the organizers of this session for inviting me. If you'd like further information about any of these topics, please do contact me. Here is my name and my email, King's College London, KCL Akak. And on that note, I will pass back to Vikram, the chair. Thank you very much indeed for your attention.
Thank you so much, Graham. That was an absolute tour de force of really a body of work that spans your entire professional career. And I wanted to just acknowledge the singular contribution that you have made to the field of understanding stigma and discrimination, amongst many others. But that was the primary focus of this talk. We've had more than 100 people sign in for this first webinar of the series, which is an incredible start, and is also a testimony to how many people wanted to hear your words. I just wanted to also let everyone know that this lecture is pre-recorded, and soon the Global Mental Health Harvard Initiative will post the link to the recorded lecture so you can share it also with others in your networks. There's a ton of questions that are already posted, and I am going to turn to as many of those as I can possibly get to. But I wanted to just turn, to you, Graham, and I wanted to ask you a couple of questions of my own. The first question is, the historical perspective. I wanted to hear your thoughts about why is it that across time and space, going back literally maybe centuries, that people with mental health conditions, particularly serious mental illness, have historically been stigmatized. We all know the stories of how people would be subjected to some of the most horrific practices before the Enlightenment brought in biomedical approaches. But even within biomedical approaches, some of the most egregious abuses of human rights occurred in the very institutions that were built to care for people with serious mental illness. So it seems that there is stigma across history and time, but also stigma, bizarrely, within the mental health professionals. That is to say, how mental health professionals have themselves treated those who they are supposed to care for with compassion and dignity. I wanted to hear your thoughts about these 2 points.
Thank you so much, Vikram. So both are vital questions, and I'm going to struggle to be brief. Let me take the first question. Where's stigma come from? Is it eternal? Have we always been, facing these challenges? And to be honest, for most of my research on stigma, I've been focusing very much upon, how do we make stigma less? Very operational, empirical questions. But recently, I thought, this isn't good enough. I should really look into the question of the origins here. And having done research, for nearly 20 years on stigma, I think, lazily assumed that, as far as we can tell, there's been discrimination against people with mental health type of problems for centuries, if not millennia. And this was somehow an eternal sort of part of our societies. That may be a wrong assumption. So I'm thinking here particularly about a wonderful book by Grinka, and I think it's called We Are All Normal. So in that book, he looks at the evidence about when stigmatization became clearly manifest. And he reaches, I think, some important conclusions. He said there is no strong evidence that people with mental health conditions were systematically discriminated against before the Industrial Revolution. He says they were sort of, sometimes people were looked upon differently, but they were all playing a role, and that although they may have been described in different, sometimes in pejorative terms, they weren't excluded from the mainstream of society in those times. He says that the critical issue was when people became producing units in post-industrial age, and when one of the primary purposes of people was to be economically active. And the conditions then developed whereby people with mental health conditions who were not able to be as economically active as everybody else were then cast out. They were seen to be useless and not playing a part in the economic maintenance of their families, and therefore disposable. And that the consequences of the organizational reactions, in terms first of poor houses, but later of asylums and institutions, as well as people incarcerated in other forms of large-scale detention, were a consequence of that basic economic imperative. So I think that's a fascinating idea. And a few other people have written about that in the same way. So rather than saying this is somehow an eternal sort of otherness, which is a regrettable but intrinsic, they're saying that stigma and discrimination are a direct consequence of capitalism. Secondly, onto your question about people working in in healthcare. So there's now strong evidence from many countries around the world that although on the principle of social contact, you might think that healthcare workers, including mental health, but primarily in physical and in primary healthcare, may be less stigmatizing. In fact, the evidence is to the converse, that often in general hospital care, in emergency department care, the staff are at least as stigmatizing as people in the general population. So let's give one example. There's a concept described as diagnostic overshadowing. So we think, for example, of perhaps a middle-aged person going to an emergency department. They've got severe pain in the lower right side of the abdomen. The receiving doctor looks on the hospital case records and says psychiatric patient and says, oh, it's all in the mind. You take this tablet and come back. But in fact, they may have a life-threatening appendicitis. If it bursts, then they could, there could be severe consequences. Now, this is not a trivial set of issues. So Druss, working in Atlanta, did a nice paper recently in JAMA, led by Walker, looking at the consequences of less and less positive treatment of physical disorders for people who have a mental health condition. As you may know, across the world, if you have any mental health condition, your average life expectancy is 10 years less than everybody else. For people, the subset of people who have a severe mental illness have an average life expectancy of 20 years less than the whole population. And fascinatingly, this is true whether you live in Ethiopia or in Sweden, whether it's 85 to 65 or 55 to 35, it's still a 20-year decrement. Now, one part of that, there are many aspects such as diet and lifestyle and so on, but one part of this is that people with mental health problems do receive less and less effective and less invasive medication and treatments for physical health problems. And indeed, I've worked, one of the guidelines I did with the WHO was on guidelines for treating physical health problems for people who also have severe mental illnesses. Now, it means then if we're going to go for stigma with respect to healthcare practitioners, we've got to even more forceful, even more organized, even more concerted. So it means having, again, social contact led by people with experience. It means having multi-channel, multimodal, because some people take in, like me, take in written information. Some people disregard the written word and like oral information. Some people like memes, some people like videos, whatever. You have a whole series of different media or channels to have a sort of impact of some of those through to the audience. And also you go for the practical elements I mentioned earlier. You don't say, don't stigmatize. You say, if you are an emergency room and a person seems to be not saying very much, poorly responsive, irritable, perhaps recent increase in alcohol use, you suspect there may be depression. And here are the specific questions you go to start screening for that. So you give very specific practice guidelines on questions of professional competence.
Yeah, well, thank you so much for that. It's a very provocative what you just said earlier, in particular about the pre-industrial age. And I think it's certainly something that we should all be mindful of. The fact that perhaps before the advent of modern industrial capitalism, that people who had diverse mental health experiences were often included within broader society. They all had roles. And that brings me fast forward to a movement that is more recent, which is the neurodiversity movement. And I just wanted to hear your thoughts about that, because there seems to be both something that I think is very responsive to the questions of stigma and discrimination by, as it were, deep pathologizing people with mental illness and mental disabilities. But also equally, some elements of that movement also interrogate whether individuals in the neurodiversity spectrum actually should be medicalized at all. And therefore, the question of treatment, for example, also becomes one that is at the intersection of these different debates. So I wanted to hear thoughts about neurodiversity as a movement of our times, how that contributes to, but also are there any concerns about that movement?
So this, as you'll know, Vikram, is a very active and indeed a controversial area. And I don't have particular expertise in the field of neurodiversity, so I'll be slightly cautious in what I say. And also in my country, until recently, most of the questions of assessment or diagnosis with respect to neurodiversity were in relation to young people or children. Of course, now more and more adults coming forward as well. So I'd make a few comments. I note that in my country, the government has become engaged in this question, partly, I think, from a genuine wish to know what is the actual truth about rates of diagnosis, of treatment and trends, but also out of a concern for a growing demand for government funding and disability support, both for young people as well as adults who may have a neurodiverse condition or diagnosis. So the debate here has gone into the really question of, are these conditions being overdiagnosed? And I think we have to be a little bit thoughtful on this and not simply jump to, a simple response. I differentiate two questions. One is it true that people, if you like, who actually have, to some extent, a neurodiversity condition or challenge, actually are having recognition, identification, diagnosis, treatment support? And the evidence is still in my country, to a very large extent, not. There have been historically very low rates of identification, and especially among adults where it is vanishingly small. And still it's the case that a minority of people who have such a condition actually receive a diagnosis. And yet the demand for assessment has been spiraling. So now in many parts of England, you can wait 2, 3, 5 or 9 years for an initial assessment if you may have, for example, an autistic spectrum condition or attention deficit hyperactivity disorder or some other condition of this sort. So I think the evidence so far, as I know, and I'm not expert in the field, is that we continue to have in some countries a very high level of underdiagnosis and underreckoning of these treatments. Now, a separate question is for people receiving a diagnosis of a neurodiversity condition, do all of those people actually have one? If you like, is there inappropriate application of the diagnostic labeling? I haven't seen data on that. Certainly some people in governments, such as my own, take the view there may be some overdiagnosis inappropriately of people who have either mild or no condition at all. But I haven't seen data, so I can't comment on that. But I do think we have to be careful here and not to be too pejorative about jumping to a simple response.
Thank you, Graham. Now I'm going to turn to this. There's a ton of questions out there, and we're not going to get to all of them. And I've been just scrolling through them, and I'm going to try and summarize some of those and invite your response to those. So there's a bunch of questions that is asking about the life course and stigma, and wanted to hear your thoughts about children, in particular, children and adolescents who tend not really to be often included, or at least not obviously so, in the literature on stigma and discrimination, which tends to focus on people with serious mental illness. Just your thoughts about the extent to which your observations and the work you and others have done in this field generalizes to or is specific to the case of children with conditions like autism, self-harm, eating problems, which typically arise in adolescence, and so on. Your thoughts about that phase of life and stigma.
Thank you. Well, I'll start on the, if you like, the stigmatizer end of the spectrum. So some years ago, in the context of a larger program, we asked the question, what do 14-year-old school children think about mental health issues? So we went in, as I recall, to about 20 different schools. In a class, we had a sort of free-form open expression format, essentially saying, shout out words, phrases, terms that you have heard used with respect to people with mental health conditions. And we noted these down, and to my amazement, we found 250 different words or phrases used just by kids in the classroom, kids in the playground, kids normally. And from memory, about 94% were negative, usually miserably negative. A couple of percent were neutral and a couple of percent were positive, but it's overwhelmingly miserable, filthy words described by young children. A clear manifestation, even at an early age, that people had picked up somehow in their earlier socialization, horrible knowledge and attitudes and verbal behaviors towards people with mental health condition. If we come on to the, if you like, the receiving end of stigma side of the spectrum, then I think this is changing rapidly. And again, I need to give a sort of caveat here because I'm not an expert on social media or artificial intelligence, but I think the widespread use in many countries now of social media and AI is changing the nature of these issues quite quickly. It's clear that many young people are finding ways to disclose mental health difficulties through social media channels, which they would not necessarily do in person, to friends, to family, to teachers, and so forth. And it's also clear that in many countries, young people are turning to sources of support from AI, including bots, for a number of reasons, including its availability, perhaps there's no cost. It may be non-censorious, non-judgmental, and so on as well. So I think I'd rather make a statement about this, say that there are very important questions opening up now about whether any of these trends, the social media, the electronic trends, are actually increasing or decreasing stigmatization. And it's clear that, although it may be clear, I should hesitate, that having a confidential discussion with a bot, now, is that social contact? Is that a form of social contact? If people want to have genuine discussion information from an electronic source about, I have these difficulties at school, might I have an autistic type problem? Might I have attention deficit problem? Is that an authoritative source? Is it one you can trust? I think there's extremely important questions opening up now for our societies, and I'd really re-emphasize the question rather than offering an answer.
Thank you, Graham. And related to the working with children and adolescents, one of our participants has asked this question: what would you like to say to youngsters who are interested in mental health and want to be the source of compassion and spread awareness about mental health problems, as it were, to be a kind of a figurative army to address stigma and discrimination against mental health? The role of people.
So I think one practical way of responding to this is the work done in Canada in recent years with widespread interventions in schools led by young people, delivered for young people. Now, by the nature of stigmatization, it is risky or can be very risky to disclose if you have a condition, even if you're trying to take part in a program which is based upon social contact. So can you actually contribute if you're interested in the field without having to say, I have or I have had a condition? The answer is yes, there are different ways. So one example would be the Indian putting on a play in a village. Now, the actors in that are playing the parts of a person with a condition or a family member, but do not necessarily disclose if they do or do not have that experience. You can actually play the part of a role. You can make it dramatic. Similarly, you can do this through cartoons, or in some countries, maybe puppets or other forms of dramatic expression where the story is told without people having to disclose that they themselves have that, because there can be risks and expulsion and exclusion that can be a consequence of disclosure. So another way is that people can get involved in other forms without having to be on the stage. They can be the logistics people, the fundraising people, the support people, the transport people who can play a part in the program, even if you actively want to reduce stigma without having to take that risky step. Or setting up self-help groups. Quite often peer and other support groups will help people to develop the narrative, to curate the story, to practice it, to rehearse it, and then decide if you wish to go public with that, or anonymize, or change your name, or go through some other form of protection for your identity. It can be a big step. And this also refers to the celebrity. The risk for celebrities may be lesser because they have all the other buffers and insulation in place. But for the ordinary person, let's say you take the step, it may go wrong. I recall a young man who had bipolar disorder. He was somebody I treated. And he said, well, I do it step by step. I said, tell me what you mean. He said, well, I'm trying to find a girlfriend. I'd maybe date a person. I'd perhaps say on an early date, I saw a thing in the newspaper the other day about sort of this mad person. And then he waited to see what the girl said. And if she said, well, don't believe everything you read in the newspaper. I know somebody close to me who had a mental health problem. They've got treatment. They're much better now. Okay, then maybe on the next occasion, he might even say, well, occasionally I get some difficulty. So step by step, contingent on the response. If, on the other hand, the date person says, yeah, you've got to be careful. There's a lot of these people about. It's very dangerous in the world, and you don't know who you can trust. Well, maybe he won't say any more on that topic, and maybe she's not the gal for him.
Yeah, well, thank you, Graham. That's beautifully said. I wanted to turn to another question, which I think is something you alluded to, but we'd like to hear more about. The question is about stigma that is experienced because of caregivers and family members who actually discriminate. And I see this, in fact, there is another related question, which is about involuntary treatment and coercion in mental health care. And I wanted to hear your thoughts about that particular ecosystem, where oftentimes the concerns of caregivers are at odds with those who are living with serious mental illness. For example, about the need for treatment and how often this actually pits family members in a very different group from those who are living with mental illness. And I've seen this also in the advocacy movements where, family members and people living with mental illness often tend to be not always aligned. So I wanted to hear your thoughts about stigma in the family and how one might address that.
Thank you, Vikram. And again, one could easily open up each of these issues and speak for some time, but I'll be brief. I think it's true that certainly from the research we've done, the family is often described as a source of great support and sometimes as a source of great stigma by individuals, especially young adults who have a mental health difficulty. So a common, if you like, storyline is that a young adult who has a mental health problem would say, I couldn't have got through the initial crisis without the help of my family. And they were tremendously supportive. And it would have been so much more difficult had they not been there, standing by me. And when I began to recover, they still kept smothering me and over supporting. And they didn't allow me to take my choices and become independent or make my own decisions or make my mistakes in my own life again. So it's a very fine balance between the support and, if you like, the overprotectiveness that quite often came through in the stories of both the people with the schizophrenia survey I mentioned and the people with major depressive disorder that I mentioned as well. The family, of course, are not just a source of support and stigma, but also quite often a source of stigmatization against the person. But it's a sword that cuts both ways, because in many studies, family members will say, we blame ourselves. There's something we've done wrong, which we think is the cause of why person, let's say our daughter or our son developed a mental health condition. And we feel shamed and embarrassed and deeply self-recriminatory for something we don't know what, that we've obviously done wrong along the way, errors of omission or commission. And also they often report that people around them, the other wider family members, the neighbors, the neighborhood, blame them for a member of the family becoming unwell. And to some extent, these are country or culture specific. As you'll know, Vikram, that in India, for example, questions of marriageability and indeed parenthood can be deeply damaged by having a mental health diagnosis. Now, you mentioned involuntary treatment. Do you want me to say a little bit about my views on this or not?
Yes, absolutely. Because one of the questions has also been about the criminalization of mental illness. Let me just explain the context. Graham, right now in the United States, there has been, the politicization of the care of people with serious mental illness, many of whom are often unhoused, and so in many jurisdictions at the state jurisdictions in the U.S., but also at the federal level, there's a growing movement towards actually incarcerating homeless individuals with serious mental illness on the grounds that they pose a threat to the public, which again, harks back to a period of time historically where, there was a sense that people with mental illness were dangerous. And of course, completely at odds with the evidence that, if anything, people with serious mental illness are more likely to experience violence than actually perpetrate it. And so, to the extent that where involuntary treatment and incarceration is again coming back into the public discourse, at least in the US, and I don't know if that's also true in Europe, and I'd love to hear your thoughts on that. Um, Clearly, there is some relationship between the notion of dangerousness, stigma, and incarceration, and it's of course a complex nexus. But just love to hear your thoughts about that. Yes.
Thank you. Again, I'll try to be brief, Vikram. So I mentioned this book that I wrote some time ago called Shunned. And although I wanted to essentially say many arguably most people with mental health conditions experience negative reactions from others, and many internalize those against themselves. I felt I must be fair to address the question, to some extent, is that justifiable? Because such people do pose a risk of harm, threat, or violence to others. If you like, are there grounds for such stigmatization? So at that time, I wrote a chapter in this book upon the associations between violence and mental illness. And from the best look I could have at the literature, I found very little evidence, in fact, very few papers on the majority of mental health conditions and a risk of violence. So if you look at phobias, panic attacks, mild depression, anxiety states, and so on, you actually don't find, by and large, you don't find data on that. And even when it comes to bipolar, certainly at this time when I wrote the book, I could find very little data. Then you come to the question about schizophrenia stroke psychosis. And indeed, then there was little evidence that schizophrenia itself confers a higher risk of threats or harm to others. Where there is strong evidence is a particular conjunction of people who have diagnoses, let's say, of antisocial personality disorder and who use alcohol or drugs and who have experience of psychosis. That conjunction of those three things, a very small group of people, and those do seem to confer a higher rate of threat or harm to others. So we've got to be very careful here, not making broad general statements, but being very specific about what we're saying. Now, it's clear, nevertheless, that in surveys in the population of discrimination and stigma, that ideas of unpredictability and dangerousness remain strong and remain a major impediment towards social inclusion. And it's both true to say that people with mental health problems are more often the victims than the perpetrators of violence, but still I think we have to look at the question, how often and what conditions people who have violent actions are people who may have a mental health problem. And of course, that's the minority of people who are violent actually have a mental health condition. So to come on to your first point then about involuntary treatment, again, I'm trying to sort of boil this down into just a couple of bullet points for today. But to try and answer your question directly, I've worked as a psychiatrist now for about 40 years. I do not believe that all forms of substitute decision making are necessarily wrong. This is in the context of people strongly advocating for the Convention on the Rights of Persons with Disabilities, who say that direct agreement to treatment or substituted supported decision making, for example, through attorneys or advanced decisions, are allowable, but that they say that all forms of substitute decision making, such as compulsory admission, involuntary admission to hospice, is wrong. I do not agree with that, because my experience has shown me a small number of people who, from time to time, are so unwell that they're not able to act in their own best interests, and there is no other supportive person to help or no advanced decision to help to express their wills and preferences. On the other hand, one needs to have very careful restraints on any such system to avoid it being exploited for the detriment to people with mental health conditions.
Well, thank you, Graham. I know this is a very complex topic and clearly not one that you can summarize, but it's just very helpful to hear your thoughts on this. Our next in the series of special lectures on May the 7th is, in fact, your colleague Charlene Sunkel, who co-led the Lancet Commission. And as a person with a lived experience, I'm sure that this is also a conversation that we're likely to have with her. It's an incredibly complex issue. And in the United States right now, I will say that the politicization of mental health problems is also twinned with the very, very polarized views on gun control. And so it may be also a particular contextual, US specific issue. But, often what happens in the US often also starts infiltrating other parts of the world. And I think that's something we should be careful about, which is the criminalization of people with mental illness and blaming people with mental illness for gun violence, as opposed to guns themselves, which are obviously the most important cause of gun violence.
Yeah, I'd agree with that. And also just to refer to your point on institutionalization or incarceration, I'm referring to people here under proper laws and constraints being admitted to hospital for treatment, not being put into an incarcerated jail or penitentiary.
Graham, thank you so much. I have my one last question for you, which I'm going to be asking all our speakers, and that is your vision of the future of the field of global mental health, and in particular, in the context of your lecture today, what is your own vision about where this field of the study and practice on addressing stigma and discrimination will evolve in the short-term future?
So I notice we have 4 minutes before our time runs out. So again, I'll just offer a couple of bullet points. I think I'd want to start with a bit of realism. I mean, you and I have been working for some time in this field. We're seeing, I think, in some areas, a greater sensitization to mental health issues. And at certain international meetings now, mental health is widely recognized as being a global challenge. At the same time, I'm just finalizing a paper with colleagues about what happened during COVID, where in many countries there was a disinvestment for mental health while resources were put into pandemic response. So I think, where would you actually put your investment? And I'd say one would be on human rights issues. Secondly, would be focusing upon detailed economic case of return on investment for governments and regional banks and so forth, given the wider global health funding challenge that we face. I think the other one I'd pick up in particular is the potential huge scale advantages of responsible support by internet, social media, and artificial channels to provide evidence-based support to people with human accompaniment at scale. And I think that the potential there is certainly greater than I've seen in the last couple of decades, but the challenges are enormous to do that in a responsible way. So I think I'd pick up those particular points.
Well, Sir Graham Thornicroft, thank you so much for being with us this morning. It's just been an incredible experience listening to your work and your views. And also thank you for the tremendous audience that we've had today and the participation we've received. Once again, just to remind you, this is the first of what we hope will become a long-term series of flagship lectures by leaders in the field of mental health, and particularly global mental health. And I couldn't be more delighted that Graham was the first in that series. I'd like to thank you all for joining us today, for your terrific participation in terms of the many questions. I'm sorry we couldn't get to all of them today. Many of you have asked about a recording. You should know that the lecture is being posted on YouTube, and Katie has put the link there. You can access also many of the publications that you'll see on the lecture directly from the Lancet website, but also through the official website of Professor Graham Thornicroft's own research group. Finally, please join us on May the 7th at the same time for the next of this lecture series, which is going to be by Charlene Zunkel, who you already heard about from Graham, but more about her when we meet again on May the 7th. Once again, thank you very much, Graham. Have a wonderful rest of your day, all of you. Thank you. Bye-bye.
Thanks. Bye-bye.